thinking about technology in a vacuum. We also need to be focused on the functionality rather than how big or how small or how fast it runs. It's more about what it does, and then focusing on those technologies that really truly could matter or could matter from a public health perspective. So from a public health perspective, focusing on a higher risk set of products, whereas focusing on functionality rather than technology, and allows platform to go to the next level. So what I mean by that is, as computing power just goes higher and higher, the size of chips and size of computers goes smaller and smaller. If we don't sort of see that should be a role of understanding if they happen to be in a different shape or size, you would regulate or not regulate them, but it's really more about what they would do. This way, we think we can promote innovation. At the same time, when we say narrowly focused, we are consciously talking about promoting patient engagement technologies, at the same time making sure that the same patients are protected if those technologies don't work as planned. That means that we need to focus from a regulatory perspective on the higher risk stuff as opposed to all the stuff, all the information and all the functionalities that may actually be on the promoting patient engagement side or may not cause any harm to patients at the end of the day. So I'll share with you a few things, a couple big item policies that we have put out. One is the mobile medical apps guidance that we put out in 2013. It basically provides a very clear sort of demarcation of what is a mobile medical, what is an app that we would be regulating, what is the app that's not considered a medical device, so it's not in purview with the US FDA. So we created these three categories. The first category is a list of products, list of functionalities that are not considered medical devices. So the guidance actually talks about that. And then you look at the next category is a list and a functionality-based approach that says it may be medical devices, but not something that we will be focusing on. So back to my previous slide, which talks about narrowly focused. And then looking at things that we have regulated in the past, the types of the pictures you see here on the screen are the ultrasound machines, the EKG machines, the radiology viewers, and diagnosis. Those are the kind of things that happen to be regulated in the past in other shapes and other sizes. So we would continue to regulate that because when people are using those technologies or those functionalities, they're expecting that those things work as intended. So by focusing on a very narrow subset, I'll tell you some brief numbers. A few years back, or actually a couple of years back, we looked at numbers that we were seeing and clearing at FDA from a review perspective. We're seeing 20 in the range of 20 apps coming to us for clearances and approval, and that's an indicator of our policy to show that if we were to look at the whole universe, which is about 40,000 apps that are out there that's looking at health, we would be only looking at 20 of those. So that allows us to focus our resources, allows us to focus on the higher risk, at the same time providing clarity for innovators to innovate in these other areas. So having said that, let me just dive a little bit deeper into what we mean by that and how we define those areas. And I will not cover all of this, but it will probably leave us for some questions. And the definition of the things that we said are mobile medical apps are the things that we would regulate. And there are fundamentally two things. One, if you take the platform that is mobile and convert it into a functionality that we have regulated before, we would continue to regulate that. Like an EKG machine, it's now in a bigger box. Now it's happened to be on a smartphone, then we regulate that. Or if it's an accessory that is now, for example, controlling another machine or another medical device, we regulate that. What we mean by regulate that is we want to make sure those technologies, when they're out there, are safe and effective. Here are some examples of things that we said that are not devices and things that we would not focus on. We as FDA has the discretion of enforcing our having compliance enforced on those regulations. We are saying upfront to people that if you're making these technologies, they may be medical devices, but that's not something we will be focusing on. And that's really what it comes down to. Let me switch gears a little bit on a really broad perspective. In 2012, the United States Congress asked the FDA to look at how should we focus on and what should be a strategy for a national health IT or health IT functionality. So the three agencies, Office of the National Coordinator, Federal Communications Commission, and FDA, got together and established a working group that sort of helped us define what should be the strategy for health information technology. And we came out with a framework in 2014 which talked about health information technology can be divided into these three large areas: administrative, management, and then medical device type functionality. There were categorization schemes that not necessarily that these are the only three. Someone could say it could be 4 or 5, but really, if you boil it down to a simple way to think about it, it could be in these 3 buckets. And in these 3 buckets, really boil down to the medical device functionality is the same principles that we have with mobile apps that we have regulated in the past, will continue to regulate. But then there's information that is managed and tools that help people deliver healthcare in a very efficient way. Those are health management functionality. We would not regulate that. And that way again, we are focusing on the higher risk stuff where people need the assurances. But we can get into detail there, but I just wanted to make sure that people understood one of the biggest things in health information technology is the decision support. The decision support software that can be in many places. Certain types of decision supports are computer-aided diagnostics. On the other hand, it could be checking for drug-drug interactions, etc. And you can see how we sort of started parsing it out. We're still working on the very fine details of what's really in and what's really out of FDA's focus. And we plan on sort of providing that guidance as well. But the point here is to take a look at what the federal government can do to contribute to this advancement of healthcare and advancement of technology reaching all patients. So I think that's really the key point to take away. And our activities sort of reflect that. And we as government are thinking that how we can contribute to this to this next level of healthcare, but also provide a path for innovators and provide a path for providers to actually have access to those tools that may enhance healthcare. We recognize that we haven't answered all the questions, so we have now set up a email box where people can ask us questions. And this is really important, and this is back to our goal of customer service. When we talk about our customers and when we talk about stakeholders, we get questions, many of those every day. And really we need an avenue for these people to ask us questions about, is my mobile medical app something that's regulated? What do I do with certain parts of digital health technology? So we have set up this avenue for people to ask questions. We have commitment in the Center for Devices where the senior leadership at the center get together, look at policies, and see, based on the questions raised, we need to solve anything that will provide more clarity. So my summary of this part is to make sure that the federal government also are nimble and also looking at how technology is evolving and also making sure that we are being consistent, we are being clear in what the real needs are. So that's an avenue. Switching gears to the international part, Raj asked me to talk about the work we've been doing internationally, and as you may have heard or not, but there is a need for international convergence. It's not just FDA and certain parts of the world thinking about how to solve or how to enhance the regulatory problem or how to enhance the access to patients and enhance the thinking and philosophy of how things should be regulated. 1, 2 should be advancing innovation and then taking healthcare to the next level. And it comes down to, if you guys have heard the Global Harmonization Task Force that used to exist, that got changed a few years back in 2011 to International Medical Device Regulators Forum. And that sort of came back from this need of, there were so many individual efforts that were going on across the world. And you can see from this list, and this is not meant for you to read on the screen, but this is meant to show you that there are many laws, many rules, many regulations and guidance and compliance activities that were going on across the world that may all aim for the same goal, but at the same time, we were looking at this picture, and the regulators were looking at this picture and going, it's time to converge. And there's always a desire to converge on thinking, philosophy, and foundation, keeping in mind that laws and statutes that in each country may be different, but at the same time we could get to the same level of thinking. So that's really what the International Medical Device Regulators Forum sort of used as an input. In addition to the regulators' action, there are many standards development activities that were happening as well. And that standards development activity also showed how many activities are required, and many industries were trying to create standards with the same goal of trying to make sure that we are all consistent. If you take a look at all of that, and if everybody is driving towards accelerating international regulatory convergence, a group of regulators got together and decided to set up this forum and made it as regulators only forum, which basically brings the thinking of the regulators into the same direction, and work on projects that can one, drive and accelerate international convergence and address the common public health regulatory challenges. There are clearly some regulatory challenges that we may not be aware of, but also do it in concert with other organizations who are also driving it. And PAHO and AHWP are official observers to this forum. In addition to other organizations like World Health and APEC are also part of this forum, not only being in all those meetings, but also making sure that they're in line with where the overall goal is for the forum. Here's some of the few things that have been worked upon by the International Medical Device Regulators Forum today. There are a few things that are completed, but software as a medical device is something that I'm leading in the forum itself, with regulators and stakeholders together. And this has been a journey for me, as well as some of the other regulators, where we were trying to come up with a paradigm and a thinking process that actually will take into account efforts in digital health in line and bring it in concert with the rest of the world as well. Here's at a very high level what we have been working on. We started off in 2013 in terms of creating a key definitions document that aligns vocabulary. And in 2014, we developed a framework document that helps people think about software, which is a key component of digital health. As you can see, information, connectivity, and technology bringing together. We needed a framework that goes, when software is used as a medical device, what should be the risk framework look like, and what the risk profile look like? So we created a document. And now we are working on something called the good quality principles for software. A lot of people may argue we already have some of this stuff, why do we need to create it? And when we looked at this problem, it seemed like there were many people doing different things. People didn't have the clarity as what the expectations are from the regulators, so we are bridging. This document is a bridging document that brings the software development community, the technology community, with the regulatory committee, and then just sharing what could be done in a better way that will enhance patient safety and effectiveness. I'm going to summarize the last few slides with just sharing with you where I think and where the center thinks in terms of what we want to achieve. We want to enable patient-centered public health. We want to foster trust in technologies. At the same time, we want to provide, internally, we need to prepare a digital future-ready infrastructure at the center that understands not only the innovators' needs and expectations, but also when we say enable patient-centered healthcare or public health, we want to understand those expectations as well. As we think about this, and I'm going to pose this as more of a question to the group here. As we continue to partner in innovations to enable better healthcare, the question is, how can technology be used to be a catalyst for, one, preventing a disease or condition, two, understanding human physiology. I'll give you some examples. One is we know preventing a disease or condition, medication compliance is one of the biggest problems across the world. People get prescribed with medicines, but most people don't take it. So what is it that we need to do from a behavioral perspective to help that? What is in healthy lifestyle? Promoting healthy lifestyle will be one of the key inflection points for healthcare, where not only prevention happens, but also making sure that the community and public health sort of takes us to the next level. In terms of the technology and medical device technology, I do want to share with you that the challenge I tell every time I speak, I ask people is, what is the next ECG of the world today? What's the next EEG of the world today? For example, in 1954, American Heart Association recognized ECG as we know today. But we're using the same knowledge base that used to be there in 50 years ago or 1954. Is it time for us to think about it differently? Do we